Okay, shall we make a start then? Welcome everyone, and thank you for joining this Centre for Longitudinal Studies webinar today on harmonisation of health measures in 5 national cohort studies. Next slide, Martina. So I'm Rebecca Hardy. I'm based at Loughborough University and I maintain an honorary contract at UCL. And I'd just like to introduce the other speakers, Martina Narayanan and Laura Gemino, who are both from CLS. And they're the ones that have done the hard work on this harmonisation project. And we're going to talk about the harmonisation of physical health variables across the birth cohort studies. Next slide. So before we get started, just a few points of housekeeping. If you have a question, can you please put it in the chat, and we'll take questions at the end of all the speakers. If you're having any technical issues, please use the email on this slide. And we'll be really grateful for your feedback at the end of this webinar. So please follow the link in the chat at the end of the event for the short survey. Very short, and it's really useful for the team in planning future events, and I'll be reminding you again at the end. And a note on the date of the next webinar, which is the 17th of July, which will explore the new data from the NCDS, the age 62 data. Next slide. So what are we going to talk about today? I'm just going to give a brief introduction and overview to the harmonisation work that we've been doing, and then I'll hand over to Martina and Laura to give more details of the process, the resources and examples of how the variables can be used. And we're going to use asthma and diabetes as exemplars of this work. And diabetes is very timely given it's Diabetes Awareness Week. And as I said, we'll then have time for questions at the end. Next slide, please. So as many of you, I'm sure, will know, there are multiple longitudinal population studies in the UK, including the birth cohort studies that are housed at CLS. And these studies follow the same individuals across the life course, collecting data at multiple time points. So they're an invaluable resource for social and biomedical research, as they allow us to look at individuals across the life course and how things change across life. Next slide. So this harmonisation project involves the British birth cohort studies, and they're born between 1946 and 2000 and 2002. So this is a slide representing these cohorts. So we have the National Survey of Health and Development, the NSHD, which were a group of people born in 1946, and then we have the 1958 National Child Development Study, the NCDS. The BCS 70, the British cohort study of people born in 1970. Next steps are born in 1989 and 90, and the Millennium cohort study, MCS, born in 2000, 2002. So this represents the years of birth and how they've been followed up since birth, and the dots on here represent when data collections have taken place. And so you can see both the time period and the age at which these collections took place. And you can see that there are overlapping years as well as overlapping ages at which data have been collected across these studies. And so although each study is really valuable on its own, these provide a really powerful resource together for studying changes across time, age and cohort. Next slide. So these studies allow us to compare across birth cohorts, and we can look at differences, for example, in prevalence of a condition at a given age. We can study whether there are differences in changes with age, and we can study how associations vary across the cohorts. I think that's the primary use of these cohorts, but we could also pool these cohorts to increase the statistical power. And this is obviously done a lot in, for example, genetics. And we could also piece together different parts of the full life course using different data from different cohorts. Now, there are multiple challenges in carrying out these sorts of cross-cohort comparisons to make them valid comparisons, and key among these is data harmonisation. So that is, we want to make variables that are included in any analysis as equivalent as possible, or at least as similar as possible. Now, although some questions and questionnaires across these cohorts have been harmonised, which we might call prospective harmonisation, retrospective harmonisation is often needed. And this involves going back and recoding existing variables to make them equivalent or as similar as possible. So in addition, that Martina and Laura have been doing work on physical health variables. This involves using data from multiple sweeps where questions don't always stay the same, even within studies. So we have to look at sort of harmonising within as well as across the studies. Next slide. So the both cohort studies collect information on multiple health conditions and health-related variables, and a selection or all of these are listed on the slide here. Next slide. And for the purposes of this project, we selected 4 common classes of health conditions to harmonise. And these were cancer, respiratory problems, diabetes, and cardiovascular diseases. And this is because these are all common and have a major impact on health, mortality, but also on quality of life, subsequent health trajectories, social trajectories, and life events. Next slide, please. So in the harmonisation of the physical health conditions, although it might sound quite easy, but as we'll demonstrate later on, there is substantial challenges that need to be considered. So key among these are consideration of the type of condition, whether a chronic disease, more like chronic condition, more like diabetes, or episodic, which comes and goes, which is more like asthma. Whether we want to understand whether a person has the condition currently or has ever had the condition, and the variable you want might depend on the analysis, the purpose of your analysis. And finally, while we can't incorporate this into the process of harmonisation, given that the cohort spans such a wide range of years, we have to bear in mind that there might have been changes in the diagnosis rates and the definitions used to diagnose these conditions over this period of time. Next slide, please. So we'll use the exemplars of asthma and diabetes, as I've said, in this webinar. And we have produced variables that have been derived, harmonised across these studies, and these will be available for use by the research community via the UK Data Service. But with also the documentation of our approach, we also provide more general learning, having identified what challenges there are with harmonising these types of variables. And we hope that these can then be applied to other health conditions and harmonisation of other health conditions. So I'll now hand over to Martina to give details on the harmonisation process and talk about asthma.
I hope everyone can see and hear me well. I'll talk a little bit about the general harmonization process, which will apply both to asthma and diabetes, but also in addition to a few specifications that apply mostly to asthma as we go along. There you go. So first of all, when we started this project, we could choose from, we had to make some decisions about what types of data to include in this harmonization process, because obviously there's the survey data, which are available on UK Data Service. There's biomedical data, which are also available on UK Data Service, but usually under a special user license. And then there's linked data, which requires also applying to access to linked data. What we have done, so what we have done now, what will be available soon on UK Data Service, the asthma and diabetes variables, includes survey data, and specifically the self-reports and doctor reports from the data files that are freely available on UK data service with a general end user license for the 4 cohort studies that we house at CLS, and variables that are available via Skylark for NSHD. And the reason for that is the purpose of this project is to give users like harmonized variables across those 5 cohorts that can be easily used, and to save time for people to not have to do this harmonization work themselves. And therefore, we wanted it to be freely available and based on the variables that are freely available. Otherwise, there would have been more issues with publishing these variables now. So it's survey data that are on the general end user license. We will in the future also include linked data, which include lots of information on health in general, but asthma and diabetes specifically, and we'll then plan then to do more work in comparing how the survey data and the linked data compare to each other. But for now, it's the survey data. The first step that we took was to document all available variables across the 5 cohorts. And we have done this documentation work not only for asthma and diabetes, but also for respiratory problems in general, for cancer and cardiovascular diseases as well. So we have lots of documentation available. And we have then, before starting the actual part of the work, we have decided to start with asthma, which I was working on, and then diabetes, which Laura was working on. So for asthma and diabetes, there are currently links available, project links on GitHub, which is a website to share code and other useful information for projects. And if you go on the link, on the GitHub link for the CLS data, especially the harmonized asthma across cohorts, you'll find a bunch of files already. And for the harmonized diabetes across cohorts, there will be more files appearing soon. If you go on the website, you will see that there's a couple of files. There's a few do files. So these are actually syntax code for the derivation of the variables that we will now make available via UK Data Service. So in theory, you could download these from GitHub today and run them yourself, because they're all linked back to data files that are available on UK Data Service currently. And you could create the variables yourself if you wanted to. So that's already available. But the other thing that is available is this asthma variable documentation. And that is sort of like a small version of the documentation that I just talked about of all variables. If you open this file, you'll see that there's different tabs for each of the study. And you will see that we have, in this first instance, included any kind of variables here. So that goes from, does the cohort member have asthma? Has there ever been any wheezing or whistling in the chest at any time in the past? Has the wheezing or whistling in the chest been in the last 12 months? How many attacks? Has this disturbed the sleep? And so on and so on. So there's like all kinds of anything that could be related to asthma in these variable overviews. And this is much more than the variables that we eventually used for the derivation of the harmonized indicator variables. But this is just to show everything that there exists on asthma in the 5 cohort studies. So then the third step was for us to just, after having documented everything available, which is a lot, the main purpose was to identify which question types and which themes are available within one cohort across time. So not just at one time point, but at multiple time points, what keeps coming back, but also which question types and content type is available across the 5 cohorts, because the main goal of the project was to create indicator variables that are harmonized variables for asthma and diabetes across all 5 cohorts. So the few questions that this applied to were mostly quite simple questions which go back to, in the end, diagnostic status of asthma and diabetes. So there are questions usually where it says, have you ever had this condition? Or since the last interview, have you had this condition? Or do you currently have this condition? And then we had a lot of other variables where they are, it's first asked if you had a long-standing illness or a condition which affects your life, and if yes, which one? So these are the types of questions that we have noticed occur over and over again across time and also across cohorts. So this is what we decided to focus on. So this is another, here on this slide, you see another sort of more or less summary of that. So basically, we boiled it down to deciding that we would focus on a diagnostic status of asthma, same for diabetes, where either it was asking about a lifetime prevalence, have you ever had this, have you ever had asthma or diabetes, or point prevalence, do you currently have it? And we included, we explored the long-standing illness type questions to feed into that. There are other variables related to asthma and also diabetes, which occur more often throughout, and that is usually age at the first diagnosis, or doctor visits in the last 12 months, or medication treatment, etc. But unfortunately, with these variables, after a while, we realized that they weren't quite as consistent over time and across the sweeps to really create variables based on those more consistently. So in the next steps, when we were actually working on coding the indicator variables for asthma and diabetes within each sweep, across sweeps, and also make it harmonized across cohorts, we didn't, the doctor visits and medication treatment type questions didn't actually feed into. What did feed into, in a way, was age at the diagnosis, not as a standalone variable. We would have, initially, we were hoping to create a variable that would indicate age at first diagnosis for both asthma and diabetes, but it was just, the information was not consistent enough across the timeline of the cohort and across the cohorts to make this happen. We did, however, include this information about age first diagnosis wherever available to feed into the indicator variables we created cumulatively over the time course of the cohort. So first, if we look at within, so we created indicator variables within each sweep and later on across all sweeps. The indicator variables within each sweep, and this is now the data that will be available in the data files that will be published on UK Data Service. This is how they are named also. It will be if the cohort member ever had asthma reported at a certain age, and these variables are binary, so coded yes, no. And that will be called, for example, asthma underscore the age of the time point and underscore ever, or current if it is a report on whether they currently have asthma or diabetes. And in addition, if there was, if the report was derived from not the parents but from doctors, sometimes we have both in one sweep, both parents and doctors reporting on diagnostic status of diabetes and asthma, then it would be indicated as a little doc. These are kind of variables you'll see. And more about how we used any items which ask whether a cohort member has a long-standing illness, and where it was usually followed up with a specific diagnostic code of the illness, which could then be coded back into asthma and diabetes. So if so, the the first decision we had to see is if there are any direct questions on asthma and diabetes, ever or currently. Because if there were, we would first look at the direct questions and look only if, in addition to the direct questions about asthma and diabetes, there are also long-standing illness type questions. If there were, then we create an indicator variable that reflects if a cohort member ever had asthma or currently. In addition, looking at the long-standing illness type questions. So let's say the cohort member, the parent of the cohort member or the cohort member themselves report, yes, I have asthma. Later on, it was asked, do you have any long-standing illness? And they maybe say yes. And again, they report asthma. Let's say they haven't reported asthma first, which is unlikely. But if later on we pick up other asthma and diabetes cases that haven't already been covered in the direct questions, it would feed back into a feedback loop to feed into those variables. If, however, there were no direct questions, and that happened at a few sweeps, there are no direct questions about have you ever had asthma or do you currently have asthma, but there are questions looking at long-standing illness. We did if there were not, then we could not create any indicator variables at that time point. But if there were, we did create a temporary indicator. And the reason why we did not use the long-standing illness type questions to create permanent indicator variables, which will be available on the UK data service, is because when a cohort member is asked whether they have asthma, yes, no, directly, the prevalence will usually be higher than if they're asked if they have a long-standing illness and what is that illness, and then identifying asthma based on that, the prevalence will usually be lower. So you miss a few cases. So there will be a temporary indicator variable which will not appear on the sweep specific indicator indicators, but it will feed in later into the cumulative indicator variables. So this might be a bit confusing, but we had a lot of exploration about this long-standing illness type questions and how we could use them and how we cannot use them, in fact. So just to give an example, in case this was confusing now, this is BCS, British Cohort Study at the age of 10, and any questions that were available and what we created for that time point. So the first questions that were available is whether the child ever had one or more attacks or bouts in which there was wheezing or whistling in the chest. And another item was, what are these thought to be due? And one of the response categories was asthma. We used both of these items to create an indicator variable called asthma_10 ever. Has the cohort member ever had asthma at the age of 10? Then, in addition to that, there was an item where it asked, have there been any other illnesses or relevant conditions concerning the child's past or present health, which have not already been described? If yes, specify. These were diagnostic codes, from which we could identify asthma. There was, in fact, one additional case at BCS at age 10, where someone was identified as having asthma, which was not already included in our asthma indicator variable. So there was feedback into. In addition to that, there was an item asking whether the wheezing occurred at any of the following ages. Based on this variable, we could identify whether there was wheezing, like asthma-related wheezing in the last 12 months, which we then coded as current asthma at age 10. And in addition to that, there were doctor reports on whether the child has ever had any of the following conditions. One of them was asthma. And in the response categories in this example, the doctor didn't just say yes or no to asthma, but they also indicated at what time frame, in which time frame the child has had asthma. So we were able to create an indicator for asthma at age 10, ever had asthma based on a doctor's report, or currently has asthma based on a doctor's report. And also here, the doctor reported whether there was evidence that the child now has or has had in the past any significant illness, developmental problem, etc., with the diagnostic code. And additional cases of asthma were identified using that and fed back into the indicator for ever had asthma at age 10 based on a doctor report. That's just an example of the variables that we created. So then after we have created all the indicator variables for diagnostic state of asthma and diabetes at each of the time points, we then create cumulative indicator variables. So that means we now do not only look at the information based on in one time point, but we go back in the past. So if the question is, has this child ever had asthma? We can look back at previous time points of reports to see if someone has reported this child ever had asthma. And we can also look into the future, if in the future is, let's say someone's not, we don't know anything about the diagnostic status, but in the future it said, no, they have never had asthma. That means then at this time, up to this time point, they haven't had asthma either. So we pull in information from the past and the future in a way and create a cumulative indicator variable that is diagnostic state up to a certain time point. So to give another example of what the data files of the harmonized variables will include, this is for asthma, for NCDS. All the indicator variables for asthma in NCDS that will be available in the data files. And you can see we have like some time points at age 7 where we have ever based on parent reports and doctor reports. Later on, we have current. One thing you will notice here is that the cumulative indicator variables that take in all information across the sweeps, they don't go up to time point age 62 and 63 here, because for 62 and 63, we only have information on current status, diagnostic status of asthma. And within asthma, and I will show a figure about this later on, excuse me, where I can show you that the prevalence for currently having asthma and ever had asthma is quite different. Like there's a difference between current and ever. So we couldn't use the current status of asthma to make any assumptions about ever had asthma up to the age of 62, 63. So if you now think these are very few time points compared to all the time points available on NCDS, you are right. And if you ask, isn't there more information available on asthma between age 11 and 32, for example? You are also correct. There is. What has happened for asthma in NCDS and BCS, there are certain time points across the lifespan where asthma and wheezy bronchitis have been grouped together. So the question would be, have you ever had asthma or wheezy bronchitis? Or do you currently have asthma or wheezy bronchitis? So for these time points, it wasn't possible for us to create a variable indicating asthma only prevalence. So what we have done as a consequence of this is we have then added indicator variables which don't just represent asthma, but asthma grouped together with wheezy bronchitis for all available time points where there's any information on asthma and wheezy bronchitis. So, and that even applies to time points where those two conditions have been asked separately. We have then created an indicator variable for only asthma and an indicator variable for asthma grouped together with wheezy bronchitis. And the reason for this is just to maximize the information we have on asthma. If the most important thing is to use as many time points as possible, you can use asthma grouped together with wheezy bronchitis if that suits your needs and you have more time points available overall. Yes, same for the cumulative indicator variables. So I hope this made sense. Let's move on. And I'll show a bit of prevalences, but when I do this, I need to just underscore that these are very rough and very raw preliminary figures. They are not weighted. There's not been taken into account missingness over time. So these are not actually representative of the real picture yet, but it's a good first look at the data. And these are showing in yellow the asthma prevalences, men who report ever having had asthma in MCS, or boys for MCS, but and then for BCS and CDS. And we see that there might be differences here, although one of the main differences that springs to your eye comparing MCS, which is the youngest cohort, with the oldest cohorts, will also be partly due to the change in diagnostic criteria for asthma that has occurred in more recent years. So part of this needs to be untangled. It's not just a cohort effect. And I'll also show you for women, because it's very important for asthma specifically to look at women and men separately, because prevalence for asthma is higher for boys in childhood and higher for women in adulthood. So it switches somewhere. I just wanted to show this one more slide. This is just for BCS. And this, because in BCS, it's quite frequent. We have quite a few time points where it has been systematically asked whether the cohort member ever had asthma and whether a current member currently has asthma. So we can quite nicely compare the prevalences for ever had asthma or currently have asthma. And as you can see, there is quite a significant difference between what appears to be significant difference between prevalences, depending on whether you ask ever had and currently have. And that's one of the reasons why we decided to be very strict when we create the cumulative indicator variables, to not use current status of asthma as an indication of ever had asthma. Now, currently we are working on using the indicator variables that we've created for asthma for a paper that will look at childhood asthma and mental health and educational outcomes. I was hoping to present some results, but they're just way too preliminary to really put on a slide at the moment, because we have to do way more work with missing data and things like that. But I will just explain to you what we're planning to do. We won't include next steps because there's only information on current diagnostic status of current asthma in next steps, not ever. But the other for the other 4 cohort studies, we are planning to, for childhood asthma, to look at a cumulative indicator variable of have you ever had asthma, up to age 11 for NSHD, NCDS, and MCS, and up to age 10 for BCS. That's what we have available. And we will, in terms of mental health outcomes, we will look both at early mental health outcomes as well as later mental health outcomes, emotional behavioral problems at age 10 and 11 for the NCDS, BCS, and MCS. So not younger cohorts, but NSHD we couldn't include because it doesn't have as much information in childhood. And then psychological distress at age 42 and 43 for the older cohorts. Similar for educational outcomes, we will look at early educational and attainment as well as later life educational levels. And that's how much I will say about asthma up to this point, and I'll hand over to Laura to talk more about diabetes.
Okay, hi everyone. I'm going to be talking about the second condition that we worked on, harmonizing diabetes across the different cohort studies. To give you an overview, really the process that we used was very similar to the approach that we used for asthma. So a lot of this follows what Martina was explaining earlier. We first documented all questions related to diabetes. We then worked on the creation of indicators at specific sweeps, and then at the creation of these cross-sweep cumulative indicators. The one bit that really stands out as sort of different from the asthma work is the work that we've done to try and create a harmonized indicator of diabetes type. So I'm going to be spending a little bit more time on that and what we've learned from that process as well, which I think you'll hopefully find interesting. So just very briefly, again, on these sort of sweep-specific indicators of having diabetes at a particular point. Again, you'll see that there are these diab_XX ever, diab XX current, and diab XX current doc variables, which essentially relate to the original variables, but with yes and no and missing data coded consistently. Also worth flagging that we cleaned and derived quite a lot of variables that fed into the derivation of our cross-sweep indicators and diabetes type. And these aren't included in the deposited data, but you can rederive them using our code. So examples of this include the temporary indicators that we used to flag whether an individual responded with diabetes to one of these long-standing illness questions. Also information on medication use, primarily use of insulin, and age that someone began using insulin, as well as self-reported age at diagnosis. So there's a lot more information on this that will be on the GitHub page, as well as in the user guide. Cross-sweep indicators derived in a very similar way to what Martina mentioned. I believe that a sort of slight difference here was we were able to make more of an assumption about kind of the relationship between current and ever having diabetes, given the kind of chronic nature of diabetes. So we also see that there's slightly less of a difference between the current and ever indicators. Note that these are currently derived just for the 1946, 1958 and 1970 cohorts, because this is where we have the most data on diabetes, but the idea is that this process can be applied to next steps, NCS, as more data comes through. So I'm now going to talk more extensively about this self-reported diabetes type indicator. So why might we be interested in producing a harmonized indicator of diabetes type? Some of you may know that there are direct self-reports of diabetes type in the 1946, 1958 and 1970 cohorts, and these are usually used to identify diabetes type, but they aren't asked consistently over time, and they are also first asked about at kind of older ages, particularly, in the 1946 cohort, the first self-report of diabetes type comes at age 53. So this means that individuals who first develop diabetes after these points won't have a type given. It's likely to be type 2 diabetes, but it still means that there isn't a self-reported type. Individuals who are tripped from the study or who missed this particular wave would also not have a type. So there's interest in kind of working to use the available data across the life course to try to infer type for those who report having diabetes. There are also some differences across cohorts in how type is asked about. So an example of this is in the 1958 cohort at age 33, there is a question about gestational diabetes, but this isn't the case in other studies. So there is interest also, we think, in deriving an indicator of diabetes type that leverages the same information across cohorts in a similar way. And again, these are derived for the 1946, 1958 and 1970 cohorts. But again, the idea is that this process can be applied to the Millennium cohort and also next steps as more data come available. Okay, so I want to walk you through the process that we came up with for deriving self-reported diabetes type. We start off with what a cohort member says about the kind of diabetes that they have. And then for those who we don't have information on, we then sort of follow this deductive process using other information, for example, on medication use and age at diagnosis. So our first port of call is the direct questions on diabetes type. So this is the first method of assignment. If someone tells us in response to one of these questions that they say have type 1 diabetes, we classify them as having type 1 diabetes. So this is, we chose this approach because we are harmonizing self-reports, and this will come up again in a second. For those individuals who we don't have a type assigned, we then move on to looking at responses to long-standing illness questions. So usually if someone reports a specific condition in response to these long-standing illness questions, these are then back-coded say to ICD-10 codes. And in some cases, we can get ICD-10 codes that would identify someone with type 1 diabetes versus someone with type 2 diabetes. In practice, a lot of the ICD-10 codes that we get in response to this are non-specific. So someone will say, I have diabetes, but they won't necessarily volunteer the type. So now we move into this deductive process where we're leveraging other information. We start off with female cohort members to try to tease out cases of likely gestational diabetes only. So we start off by looking at the reported age of diagnosis of diabetes and see whether it lands within plus or minus 1 year of childbirth. And then for those individuals that meet that criteria, we then look at subsequent insulin use and reports of current diabetes sort of later in life after reproductive years. So under this scenario, individuals who had gestational diabetes and then went on to develop type 2 diabetes would be classified in that type 2 group. So just something worth noting. And if you are specifically interested in gestational diabetes, then probably a good thing to go and look at the code. And also, the 1958 cohort, for example, has these direct questions. For those individuals who still aren't assigned a diabetes type, we then move on to looking at their reports of medication use, specifically insulin. So we make the assumption that if someone reports not taking insulin, or that they began using insulin more than 2 years after diagnosis, this is likely to be a case of type 2 diabetes. Note that we can't make the reverse assumption. So say that if someone is taking insulin and they began taking it within 2 years of diagnosis, that must mean that this is a case of type 1 diabetes, because it is possible that it could still be a case of type 2 diabetes. Then for those individuals still not assigned, we move on to these assumptions around age at diagnosis. We assume that a diagnosis or a first report of diabetes before age 20 is likely to be a case of type 1 diabetes. A case that began or was first diagnosed after age 40, likely to be type 2 diabetes. And by this point, we've whittled down most of the cases. So we're left with a sort of more of a handful of cases where we're able to look at the patterning of responses to questions on currently having diabetes. So we look for whether someone responds yes to having current diabetes in sort of midlife and beyond, and whether this was preceded by a no response, which would suggest that this is sort of adult onset diabetes and more likely to be type 2 diabetes. We still end up with some individuals who we cannot assign a type to, and these are kind of assigned the diabetes type undetermined. So we have a diab type variable, a diab type reason variable, which contains information about why the assignment was made or at what stage in the process. So to give you an overview of what we see, this is a sort of breakdown of the cases of diabetes by type. Diabetes UK reports about 9 in 10 cases of diabetes are type 2, about 8% type 1, 2% other. Our breakdown sort of overall generally conforms to that. In the 1970 cohort, for example, you can see that the proportion of cases made up by type 2 diabetes is slightly lower. It increases with the cohorts as we look at older cohorts, which makes sense. Just for context, those in the 1970 cohort are in their early 50s. So we expect that as time goes on, there will be more cases of type 2 diabetes that develop, and this will change kind of the ratio of cases. So I sort of pause here and say, that's great, but it's a little bit more complicated than that. And I think there's some really interesting learning that can come about from this harmonization process. So our hierarchy uses self-reported diabetes type as the first method of assignment, i.e. if someone says, I have type 1 diabetes in response to a direct question, we classify that individual as having type 1 diabetes. What we noticed in this process is that it's not rare that there are discrepancies between the type of diabetes that someone self-reports and other indicators. So, for example, their reported insulin use or age at diagnosis. So, for example, it's not rare to see that some individuals will report that they have type 1 diabetes, but then they'll also say that they were diagnosed with diabetes in their mid-40s and they aren't taking any insulin at age 50. So this would suggest that this is likely to be a misclassification of diabetes type. In our harmonization work so far, we've not made any sort of executive decision about how to treat these cases. We have left them coded as they are, but we have created a diab type caution flag, which indicates these cases where the self-reported type seems to not match up very well, potentially, with reported insulin use or age at diagnosis. We also create this diab type reason variable, which contains information about why the flag is observed. And I said it's not uncommon, and it really isn't. So overall, when we look at all diabetes cases in the cohorts, we see that somewhere between 4 and 7% of cases have a diabetes flag raised. This declines across successive cohorts. But what's really interesting, and this was an interesting learning point, I think, for us, was that the flags are raised almost exclusively for type 1 diabetes. And in the case of the 1946 cohort, a huge proportion of individuals who self-report having type 1 diabetes have reports also that say that they're not using insulin or that they had a relatively late age at diagnosis. And that seems to decline a little bit across successive cohorts, but still about 10% of cases that we assign to type 1 diabetes report that they're not taking insulin. So we've left this here for users to make decisions about how they want to treat these cases. But we have done a bit of exploration, which hopefully you'll find interesting. In the 1946 cohort, there was previous work done to derive variables on diabetes type up to age 53 using basically survey responses, but also medical notes that were reviewed. And we're able to compare that to the harmonized diabetes type variable that we produce. We find that the cumulative prevalence overall is very similar for the two variables. And what we see, interestingly, is that for individuals that were assigned type 1 diabetes using medical notes and survey responses, so using this other derived variable, they are very, very consistently classified as having type 1 diabetes under our approach. I.e., if we assume that those cases of type 1 diabetes are correct using the other derived variable that uses these medical notes, we're capturing them well in the harmonized data. But in our approach, we also see that we capture a lot of individuals as having type 1 diabetes who are not classified as that in the other approach, right? And often this is because they've self-reported that they have type 1 diabetes, whereas this wasn't factored into the other derivation approach, or because medical notes were used for more information, which we obviously don't have access to in the harmonization project. An interesting thing also just to note, cases of gestational diabetes that were identified using these derived variables that use medical notes are mostly assigned type 2 diabetes using our harmonization approach. And a lot of this is because these individuals then subsequently go on to develop type 2 diabetes. So this might be a bit confusing. We've written quite extensively about this in the user guide. So if you are interested in this, there is more information there. Just to quickly note, and I think this speaks to some of what Rebecca was talking about earlier, screening and diagnostic practices have changed for diabetes over time, and awareness and knowledge about diabetes and diabetes type has also likely increased across cohorts, and potentially, you could see that in the inconsistencies or the proportion of cases with caution flags raised and how that varies by cohort. To self-report having diabetes, cohort members have to be diagnosed. We know a little bit about among those who do report having diabetes, it generally seems that agreement with GP records and with biomarker data is good. What we know less about is the numbers who do not report diabetes but might have it or have it. So whether this is due to being undiagnosed or whether they have been diagnosed and are not reporting the condition. Just to note that the prevalence estimates that we get using these self-reports are likely an underestimate of true diabetes prevalence, and the extent of that underestimate also varies by cohort. So if you are interested in these harmonized data from across cohort comparative perspective, particularly looking at prevalence, it's just worth bearing that in mind. And just to finish off, you can use harmonized data for many reasons, including controlling for potential confounders, defining the analytical cohort, but you could also use it as an outcome. So this is just some very preliminary data from a paper that we're working on, looking at self-reported type 2 diabetes and childhood socioeconomic position across cohorts. The cohorts have been extensively used to look at prevalence of obesity and overweight across the life course. This is a lovely figure from a paper by Johnson and colleagues in PLOS Medicine, and you can see here the probability of overweight or obesity in different birth cohorts. So in yellow, those born in 1946, in orange in 1958, in red 1970, etc. And what we can see is that the prevalent or the risk of being, the probability of being overweight or obese at a given age is higher in more recently born cohorts. And that sort of inflection point starts earlier and earlier. So the other area where there's been quite a bit of research on BMI has been looking at social inequalities. These findings generally suggest that social inequalities in BMI in early life, in childhood and adolescence, emerge after really in the most recent cohort, so in the millennium cohort, but they're not as apparent in previous cohorts. And the magnitude of difference in adult BMI by parental social class exists across the three oldest cohorts, but is relatively similar. So given that obesity and overweight are risk factors for type 2 diabetes, we were interested in describing the prevalence of self-reported type 2 diabetes across the life course, and B, looking at social inequalities in diabetes type and whether we see something similar as for obesity. So just a caveat here, this is very much early stage preliminary findings. We plan to add in the 1946 cohort. So here you can just see those born in 1970 in red, and blue is the 1958 cohort. And you can see that prevalence plotted over age and over period. And some suggestion here perhaps of an earlier sort of increase in prevalence of self-reported type 2 diabetes in the younger cohort or more recent cohort. We look at the distribution of father's occupational social class at age 10-11. We see there are some slight changes in the distribution, with those in the younger or more recently born cohort more likely to have a father working in a non-manual occupation. And so the very preliminary work that we've done has just been to look at the association between father's social class and the risk of having type 2 diabetes at age 42 relative to those in the skilled non-manual occupational social class, and some suggestion that those individuals who are more socially advantaged have a lower risk of type 2 diabetes at age 42, although confidence intervals are wide and prevalence at this age is quite low. Another thing that we've done is that we know that there have been these changes in the distribution of occupational social class. So we have derived RIDDIT scores from the categorical data, and we look at the slope index of inequality. So essentially comparing the most advantaged to the most disadvantaged in each cohort. And interestingly, so far we find that the kind of relative increase in the risk of type 2 diabetes for the most disadvantaged compared to the most advantaged is very similar across cohorts. So as I mentioned, we plan to include data from the 1946 cohort to expand to modelling a wider range of ages and also some sensitivity work related to diabetes type. But with that, I think I conclude our overview of the harmonised data, and yeah, we welcome any questions or suggestions that you might have. Thank you.